Welcome to the Coping with Persistent Pain Current State of Science webinar. We're glad you're here. My name is Tanya Hyde, and I'll be moderating the webinar today. I'm the project manager with the Canadian Institute for the Relief of Pain and Disability. This webinar is co-sponsored by ourselves, CIRPD, and Pain BC in collaboration with the Canadian Pain Coalition, and it's also made possible through the support of the Direct Access Program through the BC government. As I mentioned, my name is Tanya, and I'll be moderating as well as handling the question and answers today. And our presenter is Dr. Francis Keefe. Frank is an award-winning professor of psychiatry and behavioral sciences, psychology and neuroscience, anesthesiology, and medicine at Duke University Medical Center in North Carolina in the States. He is one of the leading experts on coping skills for chronic pain. He is a longtime section editor for Pain, is on the editorial board for the Journal of Pain, and has written more than 300 peer-reviewed papers and has written for or edited more than 60 books. The primary aim of his current research over the past year has been to study the effectiveness of cognitive behavioral therapy for arthritis pain. Thank you very much for being here, Dr. Keefe, and I will hand it over to you.
Thank you very much, and I'd like to give a big welcome and shout out to my neighbors to the north there, and I'm sure you're all launching into the beautiful time of the year up there, and we're launching into the very hot time of the year here in North Carolina. By way of introduction, I think it's probably important just to tell a story that illustrates an important point about pain, and it's a story I think that many of you have probably heard of the blind man and the elephant. And the story goes that there was a group of blind men gathered on a street, and they could hear something lumbering down the street that was pretty large, but they weren't sure what it was. And it was an elephant, and none of them had seen an elephant before. And the animal lumbered down the street and stopped quite near them, and they rushed over to touch and hold the elephant to try to get a sense of what it was. Every one of these men had a hold of a different part of the elephant, though. So the man that had a hold of the tail said, "Oh, it's like a rope." And I'm absolutely sure of that. The man that had a hold of the side of the elephant said, No, you're totally wrong. It's like a wall. It's kind of like a moving wall, though. It's quite big. The man that had a hold of the ear said, No, you all have it wrong. It's like a big fan. And the man that had a hold of the nose was saying, No, this trunk, this is like a giant hose. It's very flexible. And they all became absolutely convinced that they knew what an elephant was and that each of the other blind men was totally wrong. And at that moment, a wise man came down the street and gave a gentle tug to the arm of each of these blind men and pulled them aside into a small group and said, wait, stop your arguing. You really need to talk to each other and listen to each other to understand what an elephant is. And the reason I tell this story is I think this is very important. This idea of individual perspectives on a problem is very important when we talk about persistent pain. And I think all of us have a view of what persistent pain is, either from our own personal experience or in talking to others, or those of you that are healthcare providers and providing care to people with persistent pain. And often we become very convinced that we kind of know what it is because we have that experience. But I think our view is colored by our own personal experience, and I think this in part helps us understand why sometimes people have such difficulty understanding pain communication from others and understanding their perspective, that often we have a bit of blinders on because of the way that we've seen pain. And I think that is very important in terms of coping, because every person that has persistent pain views their pain through a particular lens, and that influences how they judge the pain and how they cope with the pain. So let me move on now from that story to the objectives of this talk. There's really 4 objectives. The first, which I've already started, is to take some time to understand the evolution of our thinking about pain over the centuries and how that fits into a stress and coping perspective, which has really emerged over the past 20 or 30 years. I then want to talk about some of the strategies that are used to assess how people cope with pain, and what you find when you talk to people about how they cope. What are some of the key dimensions of coping? I then want to go on to discuss 4 different treatment protocols that are used to help enhance pain coping. And I'll talk about the strength and limitation of these protocols. And finally, I want to touch on some interesting future directions for research on pain coping, many of these focusing on ways to enhance access to pain coping interventions. So, conceptual background. The earliest records of ancient civilizations refer to pain and methods for pain relief. And what we can decipher in looking at these records suggests that ancient peoples understood acute pain, pain that was associated with a clear-cut injury or a disease, where there was some type of visible stigmata of the disease or the injury. What was so puzzling and curious to ancient peoples, and I would submit it remains puzzling to us today, is pain that persists, often long after healing of an injury has occurred. And the earliest explanations of this type of persistent or chronic pain were mystical or religious in nature. For example, the ancient Egyptians believed that persistent pain was due to the spirits of the dead inhabiting the individuals, and the spirits would enter through various bodily openings. And this picture is quite apropos because one of the favorite openings for these spirits to go through was the left nostril. I don't know exactly why, but that was a favorite spot. The Egyptians developed elaborate religious rituals to free people from these spirits of the dead. And what's interesting is that sometimes these rituals, in fact, did relieve pain or abolish pain totally. Now, the Western view of pain also has been dominated really for centuries by a religious notion. So the word pain comes from the Latin word poena. And I'm sure we have some Latin scholars in the audience today, if you think back to your Latin. And you'll remember poena is the word for penalty or punishment. So the word pain comes from the word for punishment. And historically in Western circles, if you go back, for example, to the Old Testament, even the New Testament, people that had painful maladies, particularly if they were persistent maladies, medical problems, conditions, were assumed to have that pain because they had committed a sin. And the pain that they experienced was a payoff, was a penalty for that. Now, I thought this was an old idea until a few years ago, while running a group with patients from this part of the country with chronic pain, there was a man who came to that group for the first time. This session was the first one he attended, and I could see he was very upset. And he didn't say anything in that first group, and I went to him afterwards and I said, what's the matter? Can you talk to us? And he said, no, I'm not sure I want to be in this group. I can't talk. I'm not sure I want to come back. And I said, well, I hope that you do come back, and I'll tell you what, if you come, you can just listen. You don't have to say anything. So he was comfortable with that, and he came back to the next group and listened and so on, and eventually in that session warmed up and told a story. And the story he told was that on the day before he came for his first group session, people from his church came to his house and said, the reason you have chronic pain is you are a sinner. And if you confess your sins to us now, your pain will go away, and you won't need to go for treatment. And this man, who was very devout, racked his conscience. He couldn't think of anything that he had done that was bad enough that he should suffer in this way. And it was very upsetting to him because he was so devout. I was shocked by this. And I opened it up to that group, and subsequently it's a story and a topic I brought up in a number of group sessions with patients. And what I found is that about half of the people that have attended some of these sessions that I've run have either had a similar experience or thought that themselves, that thought somehow they had transgressed in some way, and that was why they were having persistent pain. So even though this is an old idea, and those of us in the healthcare professions might poo-poo it, it still is a current idea, and in fact, there was a study of over 260 cultures. This is an anthropological study, 260 cultures around the world, and only in a small minority was pain understood in the kind of biomedical way that we typically understand pain. So people can have different lenses, different views of persistent pain, and think of different causes. It's not always from a biomedical perspective. Now, the traditional biomedical model dates back to the 17th century and was heavily influenced by this young rake. And I wonder how many of you know who this person was. Well, this is René Descartes. In his younger years, you may have seen some pictures when he was older. He was a famous French philosopher, scientist, mathematician, and he was very curious about pain, as he was curious about a lot of things, particularly sensation. And he wrote about pain. He wrote a treatise about pain, and he illustrated that treatise with a drawing that's an adaptation of the drawing that's shown right here. And he was the first to propose that pain is transmitted by a pathway from the periphery to the brain. So in this diagram, it's an adaptation of Descartes' diagram. You see this man getting close to the fire. Descartes believed that when you get too close to a noxious stimulus like that, fire, that a thin thread in a tubule, you'll see that tubule going up to his brain, a thin thread would be pulled, and a pore would open in the brain, and you would feel pain. And he used the analogy of a bell ringer, much like a bell ringer might pull on a rope and a bell ring at the other end. So too is pain experienced. And this traditional view was picked up by subsequent scientists, and many investigations were done over subsequent centuries that actually lent a lot of support to this view. And in fact, we now know there are in fact pain pathways, and that it does go from the periphery to the brain, and when the signals reach your brain is when you feel pain. And I would submit that for many people with pain, the average layperson, this is probably the way they think about pain. And that this view has several assumptions which are listed on this slide. One is that if you have pain, there must be a reason. There must be tissue damage, there must be injury, in this case exposure to the fire. The view also says this is a one-way system. So the brain's role is just to receive the signals, and the rest of the apparatus is to transmit the signals to the brain. And the third point is also a very common assumption, that if you have a lot of pain, it means there's a lot of tissue damage or injury at the periphery, whereas if you don't have much pain, there's probably not as much going on. So again, a very common sense view. It seems to explain a lot of types of pain. But, well, this is the system here operating, actually. There are signals, there's pain, and there's pain behavior. By the mid part of the 20th century, though, evidence began to accumulate that there were some real problems with this traditional biomedical view. One of the problems was a set of observations made in wartime situations. And one of the most famous sets of observations was made in World War II at the Anzio Beach. I don't know how many of you remember your World War II history, but when the Allies tried to capture Italy, they started at the bottom of the boot of Italy and worked their way up the peninsula towards Rome. And they were stopped south of Rome because the Germans had the high ground, and there was a lot of fighting but not very much movement going on. So to try to circumvent that stalemate, they made a surprise landing at a little beach called Anzio, which is about 20 miles from Rome. And on that beach were a number of soldiers, and they were trying to move towards Rome, but as you might expect, the Germans were threatened, Rome was threatened, so they pulled all the forces they could out of Rome and brought them to bear on this small beachhead. They lobbed in shell after shell. It was just a terrible place to be. The Allies eventually did break out and capture Rome, but it took months. And this was one of the bloodiest battles in World War II. Now, on the beach was an anesthesiologist named Henry Beecher. And he was really struck by a phenomenon that he noticed in the soldiers presenting for treatment at the battlefield station there. What he noticed was that many soldiers were coming in with obvious injuries, but reported no pain at all. And he said, well, maybe they're in shock. They don't know what's happening. They have a altered sensorium of some sort. But he actually screened out men who were in shock, who didn't know what was going on. In fact, the men that he documented, he wrote a book about his experience with 200 of these men. They were surprised themselves, given the extent of their injuries, they had no pain. He then went on to be involved in the operations for many of these men, and very few of them wanted pain medication after the operation. So what's going on here? If we go back to that old model of Descartes, we definitely have injury, but for some reason, there's no pain. So clearly, circumstances like this happen, and it's not just in wartime situations. We see this in emergency rooms now and so on. This simply doesn't fit with that simpler kind of pain pathway explanation of pain. Another problem that's also seen is a phenomenon known as phantom limb pain. So you see a man here in the middle, a veteran who was wounded, lost his leg, and very commonly men like this will report pain in that phantom leg that is no longer there. Again, how do we understand that? There's no input from that body part, yet pain is experienced. I'm reminded of a story of a man that I saw who was pretty upset at being sent to me. I'm a psychologist and I work with people with pain. He had phantom pain in his hand. And he said, this isn't in my head, it's in that hand. And what had happened is he had bone cancer in the bones of his lower arm and hand. He had the hand and lower arm amputated as a result. But after the operation, even though he didn't have cancer anymore, he had terrible pain in his hand. And the pain felt like if you took your hand right now and you clasped it into a fist and clenched your fingernails into your palm as hard as you could imagine if you held your hand like that for hours, what that would feel like. That was what his pain was like. And again, he said to me, I don't think there's anything you can do for me. And I said, well, are you willing to try something? He said, well, I'll try anything, but I can tell you it's probably not going to work. So what I did with him is I trained him in muscle relaxation. We worked on a technique called progressive relaxation, in which he tensed and then slowly relaxed muscles throughout his body. We made a tape of the relaxation instructions. I said, as an experiment, I know you think this isn't going to work, but try listening to this tape twice a day for a week. And he said, you're right, it's not going to work, but I'll listen to it just to satisfy him. So he did that, and he came back a week later and he said, it's really interesting. When I put on that relaxation tape, the hand, of course it's not there, the phantom hand, the fingers begin to relax and unclench, and I will experience 2 or 3 hours of pain relief after listening to that. So again, think about this. There's no input in phantom pain, there's no input from the hand, but if he relaxes the hand somehow, however that's happening, the pain will go away for a period of time. So all this is to say that our traditional views of pain don't hold up. And this has led to newer theories of pain, newer ways of understanding pain. And one that's particularly important for the pain and coping perspective is the gate control theory. This theory was advanced by a Canadian, Ron Melzack, a psychologist, and a Londoner, Patrick Wall, a neurophysiologist. Both were graduate students, I believe, at the time they came up with this theory in the 1960s. Now what the theory said is that, yeah, there is a pain pathway from the periphery to the brain, but the explanation is more complicated. And what is left out in that traditional model is the fact that in the spinal cord is a gate. And like the gate in your garden, it can be opened or closed. It can be partially opened or partially closed. And when it's closed, input can come from a body part such as a leg or arm into the spinal cord, but it's actually stopped at the level of the spinal cord by this gate. On the other hand, if it's open, signals can come in and go right through the spinal cord up to the brain, and pain will be experienced. An important part of this theory that Melzek contributed was the notion that the gate is influenced by what's going on in the brain. So the brain just doesn't passively sit back and receive pain signals, but in fact it's actively involved in influencing whether the gate is opened or closed. So cognitive processes, things like memory, expectation, beliefs, can influence the gate because the areas of the brain responsible for these processes actually send their own neural pathways down to these gating areas in the spinal cord. Furthermore, areas of your brain that are involved in motivation and emotion also can influence pain because they send their own pathways down to these gating areas. So let me try to illustrate that with a cartoon. Here we have in the spinal cord sensory neurons coming in. Let's say it's from an injured leg. It goes through the spinal cord where there's pain transmission neurons that send their signals up through the gate. Here you can see the gate is open and pain is experienced. So here's a stimulus might be delivered, it goes through the gate, it goes up to the brain, and you experience pain. On the other hand, you might have situations that will inhibit pain. So we know certain medications, we know under dangerous circumstances, for example, or with the use of certain coping methods, you can actually activate areas of the brain, higher centers of the brain, that inhibit pain, that actually can send signals down to close the gate. So as we see here, those kinds of things can activate that pain inhibition system such that the gate is closed. So now when a stimulus is applied to these sensory neurons, they get stopped at the level of the gate and no pain signals get to the brain. Now on the other hand, prolonged stress or anxiety or certain maladaptive forms of coping, which we'll talk about, can activate what we call pain facilitation systems. These are things that tend to make pain worse. And the gate control theory would say those things actually function to open the gate so that when a sensory stimulus is applied, the signals will go right through to the brain and you will feel pain. So when you think about this, it's quite interesting because it says that the nervous system and the brain, which is part of the central nervous system, that this whole pain system is a very dynamic system. It's not necessarily just a simple, straightforward system such as Descartes proposed, or such as we believed up to maybe 30 or 40 years ago. It's very dynamic. And as you're sitting there now, the system is constantly changing and so on, and the bias on this gate is moving open and closed and so on as we go through our day. You might say, well, this is hopelessly complicated, but the other side of it is to say, well, this also offers many opportunities for intervention. So interventions, for example, we see here that decrease stress or anxiety that alter coping have the potential to shut off this pathway to pain and maybe turn on some of the pain inhibition systems. Now, to take this even a step further, one of the most active areas of pain research right now is pain imaging. So it turns out when you deliver a stimulus to somebody, a painful stimulus, and they're in an imaging machine, what you see is lots of different areas in the brain light up, suggesting that these areas are working together somehow in the pain experience. And the update of the gate control theory is called the neural matrix theory. And what that theory says is, yeah, there are gating mechanisms and so on, but it's much more concerned with what's going on in the brain and how that's informed by the imaging studies. And the current thinking is that when we experience pain, it involves the working together in a matrix-like fashion of areas of the brain that are responsible for sensation, that are responsible for vision, that are responsible for cognitive and emotional inputs that I've talked about, that are responsible for stress regulation. That's what the intrinsic neural inhibitory modulation is, stress regulation or release of endorphins that occur under high stress. But these areas work together to create what we label as pain, and that we're sometimes in clinical settings asked to put a number on, say 0 to 10. But it's actually a lot that's coming together. And I like to use the analogy of an orchestra. So much like a symphony orchestra might have many, many players coming together to create a tune that we could put a number on, 0 to 10, oh, I really like it, it's an 8, or no, it's not so good, it's too modern, I'd give it a 2 or something. We can put numbers on things, but it doesn't necessarily mean that they're that simple in their nature, and I think that's the case with pain. Again, you might view this as hopelessly complex, or you might view that all these listings on this particular slide become opportunities for intervention, for pain interventions. Now, what happens when we study pain coping and we try to ask people about how they cope with pain? Well, this area got started really years ago based on some research by Hans Selye. And Selye did a lot of animal studies of stress, and he actually used pain as a stressor. And what he found was that as you deliver more pain, you would reliably get particular physiological outcomes. It was almost like a dose-response relationship. The more pain that you deliver, the longer the pain, the more you get a change in the physiological response. And he labeled this, it was so predictable, he relabeled the response as a stress response, or something he called the general adaptation syndrome. Now, this was very appealing to people doing human studies, particularly people who were studying individuals having pain. So the thinking was, well, it ought to be just as simple then. If somebody has more pain, they ought to show more of a change in terms of how they're adjusting to pain, physiological responses. If they're having lower pain, then we ought to see less of this. And what we saw in the actual studies was much more complex. So you could have 3 people with the same level of pain or same duration of pain, and you could see 3 very different outcomes. So in humans, it was a much more complex affair. It wasn't as predictable. The response to pain was not as predictable. And findings like these led to advances in theories of stress and coping. One of the major advances came from 2 investigators called Richard Lazarus and Susan Folkman. And they reasoned that in a human being, a stressful event like pain is occurring in somebody that's making coping efforts and that's making judgments about that event and its meaning. And that, in fact, if you took into account how people were coping, and these judgments or appraisal of the event as threatening or harmful, then you could understand much better the type of outcome that they were showing. So stress and coping theory really underscored that in humans we need to look directly at coping and appraisal or judgments of the event. So we started in our work in this area simply by asking a very simple question, coming to people with pain and saying, how do you cope? And what we found was interesting. One set of things that people would say they do are sort of coping skills or efforts. People would say, well, I make an effort. I distract myself. I try to calm myself down mentally. I do things to relax. I take medication, whatever. And it turns out you can reliably measure these different types of strategies. They're sometimes parsed as cognitive efforts. That's efforts that you make to change your thinking about the situation versus behavioral coping. efforts that you make to problem solve the situation, or it could be more active approaches to coping, or more passive things like reclining or taking medication. So that's sort of one domain of coping. The second domain turns out to be even more important, and that's the appraisal dimension. So how is your coping working for you? How are you viewing the event, the painful event? Are you appraising it as a threat, as harmful, or as a challenge? And this came out when we talked to people in different ways. Some people would say, I can really control my pain. Other people would say, the pain is awful, it just overwhelms me. So you can see differences in how much people feel they can control how effective their coping efforts are. So again, two domains here. One is how you cope, and the second part is how's that working for you? How do you appraise your ability to cope? How well is it working? Well, it turns out the second dimension is very important, and particularly the notion of pain catastrophizing. So one of the things I'll have you do now is look at this particular figure. It's an adaptation of the figure by Descartes that we saw earlier. And this diagram looks a little different. So if you look at this man, you can see a lot of emotion in his face. You can see that he's withdrawing from the fire, and he's very tense and guarded. This is somebody who is pain catastrophizing. I would imagine this man is thinking about the pain a lot, in contrast to the man that we saw earlier that Descartes drew. The other interesting thing about this man is that he's drawn others into this situation. And one thing we know about people who catastrophize about pain is that they do prefer to cope in the context of others, to pull others in, to help them cope with the pain and deal with some of the emotional difficulties that come up when you have pain. And so pain catastrophizing has been defined as the tendency to focus on the pain. You can see he's actually looking at the stimulus, exaggerate how threatening it is, and negatively evaluate your own ability to deal with pain. Now, when I ask people if they know anybody who engages in pain catastrophizing, it's interesting that very few people will nominate themselves. Many people will nominate their spouse. And I'm not exactly sure the reason for that. But I should point out, pain catastrophizing is not just something that we see in people who have persistent pain. In fact, in the general population, there are people that catastrophize to a greater degree and to a lesser degree. It's actually normally distributed across the population of normal individuals, people with medical conditions, people with persistent pain, and so on. So this is a general thing that people may do more or less of. So what do we know about catastrophizing? Well, the study started off with people with non-malignant pain, chronic pain conditions that were not disease-related, basically. And what those studies showed is that people who catastrophized, not surprisingly, reported more severe pain. They also, even after you control for their pain level, they exhibited more pain behavior. They actually looked from their guarded movements, their facial expressions, like they were hurting more. They tended to report more psychological distress and depression. They took more pain medication. They were more physically disabled, and so on. Now, one of the things that our group has been particularly interested in is, does the notion of pain catastrophizing have relevance in persons with disease-related pain as well? And this is a study which is a very interesting one that we did among people undergoing knee replacement surgery for osteoarthritis. You probably know people that have had a knee joint replaced, and we know that they end up with a perfectly acceptable knee joint with this replacement. But we also know that 1 year later, about 30% of people that get this surgery are still having moderate to severe pain. Another 40% need a cane or walker to get around. So a question arises, who does well with this surgery versus not? This is a study done by Dan Riddle at the Medical College of Virginia, where he followed patients. He saw them before operation and then 6 months later, patients with osteoarthritis who had a knee replacement. And what he looked at first is, to what degree pain at the time of operation or before the operation, to what degree they had severe surgical complications, the status of their knee implant, and so on, whether they were overweight or had other medical conditions. To what degree did that predict how they did 6 months later? He also looked at various psychological predictors that he identified in the literature might be potentially important, things like depression, anxiety, self-efficacy, and so on, and pain catastrophizing. He then threw this all into a predictive analysis, and what he found was quite striking. It was really catastrophizing that predicted which people did not do well after this knee replacement. In fact, it was the strongest predictor. So if you were a high catastrophizer prior to the surgery, it was 4.5 times more likely that you would have a poor response to the surgery. And this has led us into, with him, we've now had a grant funded to look at an intervention to try to enhance pain coping to improve the outcome of this surgical approach. Now, some of you might be thinking, well, is this all self-reported? Are there any biological mechanisms that underpin this? This is a study, and there are several of them now that have looked at the underlying biological mechanisms of this particular coping style, pain catastrophizing. In this study, healthy individuals were brought into a lab, their pain catastrophizing was assessed, and they were in a magnetic resonance imaging study. And during the study, 2 levels of pain were delivered along the median nerve electrically. One was a mild pain, and the second was a moderate pain. And what the study showed is that patients who catastrophized did not show any relationship between their catastrophizing and areas of the brain that are related to sensory aspects of pain. Pain catastrophizing, though, was related to regions of the brain related to emotion and attention and motor aspects of pain. And even more importantly, during the more intense pain, activity in regions of the brain that function in that kind of gate control fashion that I mentioned earlier, that block pain at the level of the spinal cord or above, those areas in catastrophizers were less active. So the authors of this study concluded that during mild pain, catastrophizers activate a vigilance network. They're very engaged, they're attentive, they're affectively engaged. But during the intense pain, unfortunately, the catastrophizers have a diminished ability to actually modulate the pain through the use of cortical mechanisms, and they have trouble disengaging from and suppressing pain. So one of the problems that comes up at this point, if you've been listening, is which of these 2 came first? Is it the chicken or the egg? Is it the coping or the pain, and so on? And what this has done is led researchers into intervention research. That is, if you develop a targeted intervention specifically to alter coping and appraisal, can you produce an outcome that is enhanced adjustment to pain that you don't get in a similar group that gets an intervention, maybe education or information, that is not focused on changing how they cope or appraise their pain. And a series of interventions have now been tested by researchers to see, can we actually enhance coping? And here are 4 interventions I'm going to touch on just briefly. The first is called cognitive behavioral therapy, and it involves 2 aspects. One is behavior therapy, which is essentially learning new habits to basically increase activity level in a gradual fashion, to re-engage with the environment, to kind of get more active and involved in life, while simultaneously decreasing some of the behaviors that interfere with your ability to do that. Cognitive therapy part of it looks at the thinking patterns, the appraisal patterns that occur, and the training involves learning to identify when you're thinking in an overly negative fashion, challenge those thoughts, and develop new ways of thinking that support the behavior changes that you're making. And here's an example of a typical protocol. It will start with an educational approach, very similar to the introduction that I gave to the talk today. It then goes on to training in very specific pain coping skills. There's a heavy emphasis on guided practice of these skills during pain episodes at home, and so on. And Just to give you an example, this is a study that we did of older adults with osteoarthritis, and we randomly assigned them to either receive this training or two control conditions, one that got education, another that got standard care. And what we found is the patients given the training in pain coping had significantly less pain than patients in either of the two other groups. They had significantly lower levels of psychological disability, and their physical disability actually improved at 6-month follow-up. There are now over 50 studies looking at this approach in multiple pain conditions. And one of the striking things in these studies is that the training not only decreases pain, but also improves a lot of other adjustments to pain, such as depression, other indices of adjustment, I should say, such as depression, anxiety, pain catastrophizing, and so on. An interesting adaptation of this is to involve patients and their caregivers in the training. And there are basically two ways to do this. One, an example, for example, we did a study at the end of life where partners are inevitably involved in helping the patient. And in that study, we trained partners to be coaches, to assist the patient in learning and maintaining the skills of pain control. Another example is to work with a couple. So, for example, a married couple can learn to work together more effectively to enhance their couple skills, for example, communicating about the pain or problem solving in a way that it can help the patient. An example of a study of this is a study we're doing right now working with couples who have a child who has cancer pain, and we're trying to enhance that couple's relationship and communication in a way that benefits the child's own pain. Another intervention that's been explored is emotional disclosure. We know that many people with persistent pain have trouble expressing feelings related to events surrounding their pain. So in emotional disclosure, people are asked to write for 4 30-minute sessions about stressful events and so on. And what this basically is based on is the notion that when you suppress your thoughts and feelings, it can increase your pain. These studies, interestingly, have shown that just simple writing for 4 sessions can result in improvements in outcomes up to 3 or 4 months later. And this is a particular study by Mark Lumley, where he looked at 18 studies that have been done with chronic pain with this writing protocol, and 13 of those studies had positive results. However, as you can see on the slide, the benefits were inconsistent for other outcomes, and pain was improved in only a small number of these studies, although there were positive outcomes for other studies. The final approach is one that's receiving a lot of press recently, and you probably heard about mindfulness meditation or yoga or acceptance or commitment therapy. And the goals of this is basically to acknowledge and accept the pain, to give up on fighting it actively, to accept that it's part of your life, and to live your life, to be involved in valued activities despite the pain. There have been a number of studies of this as well. So just to compare, 4 different protocols, cognitive behavioral protocols, probably the most widely tested and the strongest evidence, partner-based protocols, promising data. There are fewer randomized studies of this, but it does seem to be particularly beneficial where the partner is very involved. Emotional disclosure, very inexpensive treatment. You don't need a therapist. It does have inconsistent effects, and particularly in older adults, there are fewer studies. And finally, the acceptance-based approach, which is very novel. It integrates with some of these other approaches, and it does have fewer randomized studies, but the results are promising. So I want to talk about some clinical implications and then briefly touch on some future directions. So I think people that are clinicians, as well as people having pain, need to be aware that psychosocial interventions can help many people, in particular older adults having persistent pain. But they also not only help pain, but they can enhance psychological and physical adjustment to pain. And I should point out, although the slide says older, it's also evident in younger adults and middle-aged adults. And in children, actually, the results are even more pronounced. There are some new strategies being developed to extend the reach of these interventions. And one is to have the interventions delivered by healthcare providers other than psychologists. I've mentioned I am a psychologist, but there are very few psychologists actually available to deliver these treatments. And increasingly now, physical therapists, nurses, occupational therapists are being taught some of these pain coping skills and learn how to integrate the skills into their regular sessions with patients. Alternatively, and I know this is being done in Canada, there's work delivering these interventions to patients by phone. So telehealth approaches, which are particularly effective for patients in rural areas who are disabled and can't come in for treatment. And this does really appeal, we found, particularly older adults and men. This telehealth approach is very appealing in people with arthritis and cancer. Another approach is internet-based programs. And I should point out, this slide is to remind me that these approaches are often used in combination. So around the world, there are many investigators developing and testing internet-based interventions for people with pain. And this has some real advantages. You can take an evidence-based approach, like some of the ones I've talked about, and you can reach a large number of people at low cost. Most of these approaches, you don't use a therapist. You can make the learning interactive, so it's not simply reading what's on the screen, but actually interactive experiential learning. You can tailor the learning to the patient's own needs. An individual can proceed at their own pace. They can track their progress through online recording and so on. And I know many of you are probably thinking, well, less educated and low-income people won't access this. But we know that there are significant gains in access to the Internet among those populations. And there's an article here if you're interested in learning more about that. A second approach, I'm sure a number of you use this, is FaceTime or Skype or other voice over internet. I don't have anything to do with FaceTime or the Apple group or Skype or anything, but these are just examples of voice over internet interventions where patients can have a tablet in the home and interact face-to-face with a therapist. And as you know, these tablets have advantages because you can turn the tablet around and the patient can show you their environment. So the patient can say, this is my kitchen. Here's why I have trouble standing at the stove or whatever. Or they can say, these are the stairs I have trouble getting up and down. And the therapist can actually ask the person, okay, go up and down the stairs and let me see how you do that, and provide coaching and instruction how to use the pain coping skills they've been taught in that situation. Or someone can engage in a valued or pleasant activity and, again, model for you some of the challenges they're experiencing with pain while they're doing that. So these offer increased opportunities for access and dissemination. So just to conclude, our understanding of pain and pain coping really has advanced a lot over the past 25 years. We now know that we can assess and measure pain coping reliably and simply. There are brief measures, which I haven't touched on in the interest of time, of pain coping that can actually be integrated into clinical practice. And by using those, we can understand somebody's pain better. And I think the exciting direction for the future is integrating the type of training I've talked about to enhance pain coping into ongoing medical care. And by doing that, focus much more directly on early intervention. And if we do that, think of the advantages. We can prevent pain, we can improve the quality of life, and most importantly, I think we can reduce the unnecessary suffering that many individuals with persistent pain experience. So I'd like to close by thanking the many patients and caregivers that have participated in our studies, support from the NIH and other foundations that have supported this work, and finally, thank you for attending today.
Great. Thank you very much, Dr. Keefe. That was a very good presentation. I think you made a lot of very clear assessments of coping with chronic pain. I liked a lot of your historical references, too. Those were very helpful. Let's see. I'll go to some questions now. Barbara asked, does anticipating pain open the pain gate, so to speak, quote unquote?
Yes, it does. And in fact, there was a really nice imaging study recently finding that looking at the area where pain stimulus is being delivered, and many of us have found this trick already. So if you're looking at that area, let's say somebody's going to deliver a pain stimulus, a heat pain stimulus to your arm, you obviously can anticipate it. And also, you begin to see areas in the brain lighting up. Even before the stimulus is delivered, the same pain areas are lighting up, kind of revving up. Whereas if you look away, those areas are not as involved and until the actual stimulus is delivered. So anticipation can definitely influence the pain experience.
Great. And then we have another question, one from Clint, asking how can an individual assess their own extent to which they catastrophize?
Mm-hmm. Okay. That's a really good question. There are some catastrophizing instruments on the web. You can download them and you can complete them and so on. And you can see kind of where you fall with that. But I would say, many of us know, if we're catastrophizers, we know that we tend to ruminate about pain. We tend, compared to others, to really feel helpless about it and sometimes magnify that pain. And I think a number of us know that we're like that. And one of the things you might feel, well, I'm that kind of person, I'm never going to change. But we have actually found that people who tend to catastrophize more do better when training with pain coping, and they can actually drive down their catastrophizing and they actually respond better to training in pain coping skills, presumably because it's something that connects with their needs and what might be helpful for them. So I think this is one important thing about catastrophizing. Sometimes we think, well, it's just a trait. I'm kind of born with it. Some people are actually looking at the genetic components of catastrophizing. And because it's a trait, I can't change it. But that's really not true. It can be changed. It can be altered. And in fact, you can do very well with training in pain coping skills if you are a catastrophizer.
Very good. And then a question from Sandy, wondering about how you deal with pain where you go to bed and you're okay, but when you wake up you're in pain. And is there anything to do specifically about that?
Yeah, I'd have to know more about the history and so on to understand that. I certainly know that people can have pain that wakes them up, in the night, that they don't sleep well, and that can contribute to the pain. We do know that many people will tell me, they're very, very active in the day, and they don't really notice their pain that much until they lie down in the evening, and then it disrupts their sleep. And to me, that's often an indication of somebody that probably is overdoing it in the day and needs to pace their activities a bit more in the day. But pain on waking, I think, is something that you probably want to explore more fully with your healthcare provider, and they may have some insights into what is triggering that pain overnight.
All right, and then another one from Sandra. Have you found that using an antidepressive as adjunctive therapy is often helpful when dealing with catastrophizing pain?
That's a good question. I'm trying to rack my brain to think, has there been a study looking at antidepressants' effect on catastrophizing? I don't actually know, but the catastrophizing literature is huge. I should point out about catastrophizing, I've been working in the pain area as a psychologist since 1978. Pain catastrophizing is the single most robust psychological correlate of pain. So I've looked at things like depression, I've looked at personality, anything you can think of, anxiety, neuroticism. Pain catastrophizing is more powerful. And even if you control for the effects of these other things, it's still a powerful predictor. We do know that antidepressants help pain. Even if you're not depressed, they can help pain. If I had to put money on it, I would say that an antidepressant would reduce the tendency to engage in pain catastrophizing. I don't know that there's actual study to that effect, but it would not surprise me at all.
All right, and then a question from Karen asking about how the pain gate is influenced by stress and anxiety you mentioned, but she's wondering, is it also influenced by fatigue?
Yes, Yes, I think it is very influenced by fatigue. And certainly we know one of the main benefits, for example, of relaxation training as well as activity pacing is lowering pain. So yes, I think fatigue can contribute significantly. And obviously if you're not sleeping at night, that can contribute to fatigue, and there's a kind of vicious cycle. We've been very interested recently in people with comorbid conditions, for example, persistent pain and insomnia, or persistent pain and obesity. And we have a couple of studies, but the one I want to highlight is the one with persistent pain and insomnia, where we find that combining a behavioral program for pain management with a cognitive behavioral program for insomnia boosts the effects achieved with either one alone. So treatment of combined conditions, and many people with pain have comorbid conditions, can really enhance your outcomes.
All right, and then question from Carmen. Do you find that painkillers such as oxycodone aid or hinder in the pain coping skills one may have? And then also, can long-term pain cause memory issues?
Okay, two really interesting questions. Obviously, one of the things with any pain medications is that you habituate to them. So you need over time to increase that dose. And this is something that concerns doctors, and one of the reasons that they try to taper medications, keep them at a lower dose to enhance their long-term effectiveness. One of the things I just learned, I just came back from a pain meeting in New Orleans, and I learned that another approach to pain, a transcutaneous nerve stimulator, I've known this for years, works for about 80% of people in the first week or so, but by a month is only working for 20 to 30% of the people. And I was curious, why is that happening? What we now know is that a TENS unit works by releasing morphine-like substances in your body. And just like you can develop habituation to an opioid or a narcotic medication, so too you can develop habituation to your own morphine-like substances. And so what's recommended now is that you use short bouts with a stimulator, and that if you use short bouts throughout the day, you're going to be able to sustain the positive benefit of a stimulator over a long time period. With regard to cognitive functioning, this has been a very active area of research, and that some of the problems that occur are in executive function, and particularly the ability to pay attention. And we know that it's very difficult when you have persistent pain to disengage from the pain and turn your attention to other matters on hand. So those kinds of aspects of cognition can be affected. The good news is that when pain is managed more effectively, those problems decrease or go away.
Great. Thank you for that. And I think that we'll go ahead and wrap up. And thank you very much for joining us. And thank you very much, Dr. Keefe, for your presentation. I think it was very informative.
And I'd like to thank the audience. I thought these questions were quite good.
I agree. They were very good. Thank you, everyone, for attending. And we will hope to have you at our next webinar.